And I told her, yeah, we can do a hysterectomy, but interestingly, you could tell, I got a feeling there's something. I never, ever discuss fibroids without talking about, you can take the fibroids out, not just the uterus. And she didn't want a hysterectomy. I mean, she thought that was her only option. And when she found out we could do a myomectomy, all of a sudden it was a relief for her. And there are percentages. There was a study in Germany. Now, obviously it was a younger age population, 25 to 50. 25% of the women in that survey said they weren't going to have a hysterectomy unless it was cancer. So it is a case that many women don't want hysterectomies. And so if you don't want a hysterectomy, we're not going to try and push you to a hysterectomy. Excuse me. But now, sometimes hysterectomy may be the only reasonable option. And so, I'm going to challenge my patients to think about the outcome and how do they want to picture the outcome. But if a woman doesn't want a hysterectomy, I'll try very hard to help her short of a hysterectomy, because how would I want to be treated? So the difference between laparoscopic surgery and open abdominal surgery, a walk in the park, a night and day kind of experience. But what's really exciting to me is a procedure that I think is going to change a lot of how we do things in the near future, because we participated in this study, and we started about 3 years ago, and we wrapped up the study a couple of years ago. We've already got patients in 2-year follow-up. And then just last spring, the FDA approved the use of this technology for women. And this is a company that had been working on this concept for the last 15 years. I can remember sitting around with my colleagues at society meetings, 10 years ago, going, hey, wouldn't it be great if we could do this? And now it's going to be available. Now a small company has to, go get a big bank loan to make this happen. So we will see the rollout. I have an appointment with them at the end of this month, because they should be rolling it out. We should be seeing the first units available in the United States very soon. This technology is already available in Europe. They've gone through a few changes. It's called the Sonata system, and Sonata is kind of an acronym, but it's really what we call radio frequency ablation. Now, radio frequency is a big long name for zapping the heck out of the fibroids with an electrical needle. So you can see up here, this is an ultrasound monitor. So this is done with ultrasound. And what happens is the woman who has fibroids, this procedure allows us to put an ultrasound probe directly inside the uterine cavity. With that ultrasound probe being directly inside the uterine cavity, we can now image the fibroid on this monitor. And while we're imaging that fibroid, there is a needle guide attached to that ultrasound probe, and we can insert a needle right into the middle of that fibroid. The technology is so cool that there will be 2 circles that appear on the screen. One is a red circle and the other is a green circle. The red circle will tell you what is ablated, what is zapped, and the green circle is what's the safe zone. You're not going to hurt anything as long as you stay within this green circle. And that way we don't end up damaging tissues outside of the uterus. So a woman has several fibroids, not just the woman with the one submucosal fibroid, but this woman who has several fibroids. And we see those ladies with several fibroids. And one of the challenges is you can do a hysteroscopic myomectomy, but you're not going to remove all the fibroids that are further from the cavity. You can do a laparoscopic myomectomy, but you can only get those fibroids that are close to the outside. It's those little tiny fibroids in the middle, and that's, yeah, Donna's has this diagram, but unfortunately it doesn't show the woman who has all the little tiny ones that are way away from the cavity. So, yeah, bring that one over. So, but this is the lady where she wouldn't need a laparoscopy because we could zap that one with the device. We could zap probably all of these. Now, the ones inside the cavity, that wasn't something we chose to treat. That wasn't in the protocol, because if they're totally in the cavity, the concern was they'll be expelled, they'll cause pain. And so we only treated the ones that were definitely inside the wall. But the nice thing about this is this allows you to treat those fibroids that you can't get either way. So the woman who has the 10-centimeter fibroid, we're going to do her laparoscopic myomectomy. But then after that fibroid's been removed, I'm going to go down and I'm going to put the probe inside the uterus. I'm going to treat the other 6 fibroids that I could have never gotten to with this Sonata technology. So it is just, to me, the most exciting technology that's been available. And I'm so excited that we're about to get it now. We treated patients, actually we treated it here in the office because it had to be one where this was the sole treatment. And so we treated them in the office with IV sedation. And I'm gonna toot my horn a little bit. I'm very interested in pain control. I'm very interested in minimally invasive surgery and less painful procedures. I tell folks I'm allergic to pain myself. And so this procedure is so minimally painful that our concept was to do them in the office with sedation, and it is a great way to go. Now, it wouldn't be for every woman, obviously. But my interest and the interest of other physicians who were interested in doing these with these less anesthetic techniques and not in the hospital to try and help with medical cost. So, one of the things we do at the society meetings is we present our research, and the company controls the data, and they can determine who does and who doesn't do the research projects. And so out of this study, there were 20-some of us as researchers, and approximately 6 of us submitted abstracts to the society meeting. And the lead researchers, they got the really cool data showing how much bleeding was reduced and how much the fibroid shrunk. But my interest was more in how to do this with less invasive technologies, more office-based, because it's a way to save a lot of medical dollars. And the society recognized that because I received the award for the best abstract in new research. So I have a little plaque on my wall that says, the society saw that this concepts were something that were very important to look at in terms of how we take care of patients, because it's not just the fibroid, it's not just the pathology, it's the person attached to it, it's the cost of the care provided. And so the Sonata technology is going to allow us to treat more fibroids more effectively so that women don't come back for another procedure as soon as they have historically. It's just such a cool technology, and it's right here, right now. We're going to be offering it very soon, and to help women with one more fantastic, minimally invasive tool. It's just been years waiting for this, the most minimally invasive of all technologies for fibroids. So Donna's can tell you about it. She participated in the study. She did the pain score. She did the smiley faces for the patients. She checked them in and checked them out. So, what do you think about it? You've seen this stuff for years.
So, well, the patients were very happy. there are many patients who are just afraid to go to a hospital, and patients that don't want to go under general anesthesia. So we were one of the, I think, the only site that did them in office. I can't say for sure.
Yeah,
We were the only one that did them in office, and we did them with IV sedation. We had an anesthesiologist come in to push the IV meds, and we used Versed and fentanyl so that our patients stayed awake. Because if we'd used propofol, they would have been like when you get your colonoscopy and you're completely out. We wouldn't have been able to get the pain scores from the patient. So during the procedure, I had this little ruler that was part of the study. It was approved to use for the study, and I would hold it up to the patient, and it had smiley faces on it, and they would slide the ruler to how they were feeling at that time, whether they had a frown on their face or a plain face, or they were smiling, they were happy, things were going well. And that's how we gathered their pain scores during the procedure, because they were awake and could respond to questions, and got up and they were out of there and home in a couple hours after the procedures. So everybody has been very happy with the outcome. We're actually into the 3-year follow-up. I'm mailing out 3-year questionnaires follow-up for the patients that we treated. Now, with any procedure, unless you do a hysterectomy, fibroids can always come back. So, you know, just because we zap all the fibroids you have, if you're young enough to continue to have menstrual periods, those fibroids could come back. You could need an additional procedure in a few years as they come back and your bleeding gets heavy again. But it was a lot of fun to do it in the office, and when your patients are happy, that makes you happy.
Well, yeah, but if you're gonna have to have another fibroid procedure, wouldn't you just assume go into the office, have a little IV sedation, go home, and the next day go out to breakfast with your sister? One of our patients did.
So, she did. And I was just gonna throw this out again about our medication study. The Primrose study is, you do get a lot of medical tests in the screening. You're gonna have blood draws, so your physical exam, your pelvic exam, your breast exam, your ultrasound. You also get a bone mineral density test.
Mammogram if you're over 40.
Mammogram, yes, if you qualify for that. We also do the endometrial biopsies, and I know those are scary words to some people, and if you've ever researched it online, some people say, oh, there are horror stories out there. But we do them here in the office, and most of our patients just do it with taking ibuprofen, 800, 600, 800 milligrams of ibuprofen. We do offer PL meds. We can offer Valium and Percocet, but you would have to have a driver. So if you are a little nervous about having that endometrial biopsy, we can give you medications to help you relax and to help with the pain, but you would have to have a driver. We're not going to give you meds and then say, now, be careful driving home, don't run any stop signs or stop lights. So you would have to have a driver if you wanted to take any additional medications for those biopsies. But they're very fast, Dr. Moore. Usually from start to finish, it's
Seconds.
Yeah, seconds to get the biopsy. It takes us longer to set up for the procedure than it takes him to get that tissue. And the reason we do that is we want to make sure that there's not any cancer or anything in the uterine lining, the endometrium, that's causing your heavy bleeding. We want to make sure that it's due to that fibroid and not due to a worse cause than just
Well,
the
the
fibroid.
FDA
So,
mandates that. We have no choice in studies. but in regular care, it's necessary to do biopsies sometimes. And there's always ways to do biopsies, and sometimes it's just gonna hurt a little bit and it hurts like hell. I always think about, and I read this once, so it's not my original statement, but what if I were on the other side of the spectrum? What would I want? What if I were the patient? And that's why we offer meds for any office-based procedure. We don't want patients to feel like they're forced to suffer through things. Even for IUD insertions, we offer meds just because I've heard too many horror stories. I always think about, what would I want if it were me? And I would want the least pain possible. So we want to care for you as best we can by offering you the most accurate diagnosis for your problem, then offering you the state of the art, those things that are subspecialty care, because this is a focus of this institute. We don't deliver babies here. We focus purely on advanced gynecologic care. And we can offer a lot more things than most general OBGYNs are able to offer. And it's really worth getting a second opinion. If anything, it just reassures you you're on the right track.
Dr. Moore, what would be considered heavy menstrual bleeding? Is there a certain criteria?
Yeah, most women on a heavy day change a pad or tampon every 4 to 6 hours. That's kind of average. Now, if you didn't grow up around other menstruating women, and I see a lot of this of women not really realizing what their periods are like until they get into college.
Mm-hmm.
You know, maybe in high school it's kind of an awkward time for all of us, and you know, you're having these periods, and you know, your mother may be a source of information, but some families just don't talk about this very often. And so I oftentimes hear, it wasn't until I got into college that I realized how heavy my periods really were. Anytime you're changing pads or tampons every couple of hours, and they're pretty saturated, that's getting on the heavy side. So you know, 12 tampons a day, 12 pads a day, that's getting heavy. I mean, even when you're changing every 2 to 3 hours, you're kind of on the heavier side.
Okay. Thank you.
Oh, thank you, Janine. That was a great question. Yeah, it's, you know, unless you have something to compare to, but you know, and then it depends on what kind of products you're using. I mean, there's regulars and there's super dupers, so you know, it makes a big difference. And you know, I tell you, the stories of women doubling up on products and putting in 2 tampons, and it's just, you know, stories of, you know, once those planes go into landing mode, you can't get up and go to the bathroom. And if you soak through your products and your clothes and the whole plane seat's pretty bloody, you just kind of sit there till everybody's kind of off. And the flight attendants have had this happen more than once. You know, they just kind of help you get taken care of. But, you know, it's sad. And, you know, one of the questions we ask on some of the studies, I mean, do you take clothing with you during your period? Do you make preparations because of that heavy flow? And I mean, if you're doing that, I mean, if you're out there and you're taking extra products and extra clothes, when you want to go someplace, or you're saying, I can't do that this weekend, you know, you're living your life around your period. Maybe it's time to do something about it. Maybe, you know, that quality of life. So 2 days a month where you're housebound, at the end of the year, that's almost a month. That's like 24 days you've lost because you're heavy bleeding. So you know, if you're having heavy bleeding, if you're having horrible, painful periods, if you've got fibroids and want to do something about it, we can offer you the least invasive, least painful options. This is a focus of this institute.
I have another question. Can it cause painful intercourse?
Oh yeah, big fibroids can cause painful intercourse. You know, it's just, women describe it as the penis is hitting something and it hurts. So yes, we see a lot of pain with intercourse, we see a lot of heavier flow, a lot of worse cramps, frequent urination. When they get really big, they seem to press on the rectum so the woman feels like she's constipated. It can just be, life altering. And a lot of times it happens very subtly. And so I'll ask questions and a woman will say, I don't really have that frequent urination. And, but it's after the surgery. They go, wow, I didn't realize how much of a problem it really was.
Wow.
And it's because they had grown so used to it, because it had been so slow and over time, that it become the new norm for them. And so to all of a sudden now feel like your clothes fit better, and it's really like bladder retraining. Because some ladies, they just simply don't know that, their bladder can hold more urine. And I've gotten more than one phone call by a concerned patient that hadn't urinated in 5 or 6 hours. And it wasn't because there was anything wrong, it was because instead of the bladder being compressed by a fibroid, the bladder could expand without the compression factor.
Okay. They can also come out of the cavity, right? That if they can pass the fibroid, right? Can it be passed at any time?
Yeah, the uterus will expel the submucosal fibroids if they arise very close to the cavity. So as they grow, they kind of pop out like the one in the drawing. It's towards the bottom, I think. Yeah, no, we got it there. So when they're like totally in the cavity like that one, then sometimes the uterus will expel those. And we've seen a number of patients who've come in because they've been bleeding nonstop for 2 or 3 months. And some days are incredibly heavy, and some days they just flood. I mean, they'll just go right through everything. And I mean, their clothes. I mean, it's just, the common phrase, it looks like a crime scene. And, they'll come in, they've been bleeding nonstop, they've been having a lot of pain, and what we'll see, either on the ultrasound or through the physical exam, we'll see a mass protruding from the cervix, or in the ultrasound, we'll see the fibroid where we know it's in the cervical canal and not. And I've done many a removal in the office of a pedunculated fibroid that's being expelled from the cavity. And then all of a sudden everything's good again. So, those are fibroids that they don't happen very often because most fibroids are deeper inside the uterus, so the uterus can't really expel them like some of these others. So the bleeding goes on for years, and then just get sick and tired of the bleeding, and it's just, you don't have to have a hysterectomy if you don't want it. And with this new technology, we've got way less invasive and way less painful options now.
Awesome.
You were going to say something?
Well, I don't know if you just tell them what a pedunculated fibroid is.
Well, pedicle is a stalk. It's,
So, but sometimes they're misdiagnosed as a polyp, right, in the uterus as well.
Well, yes. I mean, you can't always tell the difference between polyps, which are tumors of the uterine lining, or a fibroid, which is a tumor of the uterine muscle. So you have to look inside. Even at that, sometimes you have to try and biopsy them just to get a sense of a firmer, more solid tumor versus a softer tumor. But yeah, when they're protruding out the cervix, they can look like a cervical polyp. It's just, the whole history, the whole presentation, the exam, and the accuracy of the exam that's important. So this is our first Facebook Live event to try and create awareness about fibroids. If anyone is still out there, thank you for being here. If you've learned something, I hope this has been beneficial, certainly learned about new technologies that are available and ways that we can help folks that not everybody can. We can help with FDA studies, and again, we'll be offering this new technology, the Sonata system, very soon. So if you know somebody, forward this information on to them. Please let other women know so that they can find help that, you know, is way less invasive and way less painful. So, do we have something in, Janine, or just kind of helping us out? So she's like the producer back there, you know, she's got it all, you know, these guys are great, what they've done, all this technology, it's been just fantastic. Tier, would you like to come out and say hi to, Tier, I'm gonna be
Tier
faceless. So, he might be wanted in another state or something. Okay, well, my humor's not that great. Should we just wrap it up? Because I think we've talked about pretty much everything we wanted to talk about. And thanks for sharing some of those questions, folks. And so, keep the questions coming in. We are offering free consultation on the 23rd to help women. And we'll be back next Tuesday to share this information.